So we're going to go through our C1, C2. This is a critical technique. Some would even say that the atlas is a keystone to other regions of the spine and even certainly regions of the cervical spine, such that if there's hypomobility at this level, then it can otherwise influence other segments below and or create signs and symptoms and stress concentrations within the spine, leading to other subsequent complaints. And so if you were to walk away with one cervical spine technique from today, I hope that this is it. Or this would be a good one, I should say. All right, so, we can, to each his own, right? So if you feel more comfortable with your cradle grip versus your chin hold, whichever one you feel most comfortable with, but I'd encourage you to practice both, all right? So let's just kind of go through our mechanics. Again, patient setup, okay? Knees bent, feet flat, torso and curvatures of the spine otherwise taken up, and little tension on the cervical spine. He's a little bit extended just because of the thickness of his torso, so I'm going to raise him up. And then the height of the table, so in this case, I'm going to use the cradle grip, okay? So that should be my 20 to 30 degrees carrying angle, and then the apex of his head should be, if I look down at the head of the table, and then just the pillow is pulled out a little bit to allow me to get my hands under it. So with my short applicator, I'm going to want to go, if I'm C0, C2, so my contact is going to be, again, the the proximal phalanx or the middle phalanx of my index, buttressed with my middle finger. I'm going to find his nuchal line. I'm going to drop off into the trough or the gutter, and then my hand's going to come, my thumb's going to come over the ear. It's going to be a high arc of rotation, close to the angle of the table. If I was going to go OA, I'd go higher than that angle. For the long lever applicator, again, it's going to be, here's the axis of his head and of his cervical spine that I need to rotate around or side bend regarding whether I'm doing a downshift or rotary technique. So as such, some will use the analogy of the 8-ball, if you will, where essentially use his nose as a means of, I need to kind of use that to get a gauge as to where my hand is relative to my axis. If I'm too high, I'm not going to be able to get around or underneath that axis. And if I'm going to add in the lateral brake, then I want to be directly in line with it. In this case, I'm going to add a little bit of rotation, and then I'm also going to add a little bit of side bend. So it's going to be a combination. So thus my contact is, or my long lever applicator is going to be over his ear. When I go into the thrust technique, a quick onset and a quick arrest is going to allow you to be more efficient and effective. What I mean by that is that you're going to spin the ball, that is his head, either into rotation, a little bit of side bending, and then you're going to, and that in itself is going to create a cavitation. But then I'm going to arrest and have a quick stop, whereas the head is going to stop, and the joints of the cervical spine, based off the momentum, will continue on, and you'll get additional cavitations at different levels. Again, we know within the cervical spine, we're looking at 3.57 pops that we would expect. We have a 90% chance of them occurring on being in a bilateral event. And we also know that there's multiple audible frequencies that are occurring. Thus, it's not just the physiological phenomenon that we have seen proven in the MRI, where you're just creating the gas bubble, that there's likely other meniscoid and or restrictions within the joint capsule itself that are likely also occurring. And so the more that you can add in the vector of onset and arrest, is likely that you're going to get more of those lesions and or implications for the mobilization. Okay, so what is our recipe and our ingredients? Our ingredients are rotation away. We get it for free. My short lever applicator is going to come in over the ear. You can't see the short lever applicator right now just because it's like in on the other side, but it's the same as I just showed. Okay, I'm going to side bend away, or excuse me, rotate away, side bend towards, right? And I get that through my whole body weight shift. Okay, and then I'm going to side glide, PA shift, and then I'm good to go. Notice that the elbow is out, and I do a couple of preliminary bumps just to get a feel for it. And then a thrust with a counter rotation and side bend. Any questions? Is it okay for you?
Yeah, great.
Okay.